Well, it's a pleasure to be speaking to you this year for the clinical pharmacology workshop. And I'm going to very briefly cover what we know about the use of small molecules and monoclonal antibodies as antiviral therapy for COVID-19. These are my disclosures. Today, I'll cover really two areas within this broad topic. That is the use of RNA-dependent RNA polymerase inhibitors, speaking specifically about remdesivir. I won't have time to cover the still investigational drugs, molnupiravir and AT-527. And then I'll speak about the monoclonal antibodies. Five of them, four of them are given as pairs, bamlanivimab and etesevimab, casirivimab and imdevimab, and sotrovimab, all of which are being used in the United States under an emergency use authorization. Well, let's start by speaking about remdesivir. Remdesivir is an RNA-dependent RNA polymerase inhibitor with broad antiviral activity against Ebola, SARS, MERS, and of course, SARS-CoV-2. Interestingly, it was studied previously in a phase 3 trial that compared broadly neutralizing antibodies to remdesivir against Ebola, in which it was found to be inferior. But it was shown to have activity against MERS in murine and non-human primate models, and to be effective against SARS-CoV-2 in the non-human primate. And in vitro data showed that there was an EC50 of just under 1 micromolar. The clinical trial on which the first authorization of remdesivir was based was the ACT-1 study, which really remains the pivotal trial in many ways. This was a placebo-controlled, double-blind, randomized controlled trial in hospitalized adults with COVID-19 pneumonia. They were randomized 1-to-1 to receive remdesivir or placebo. The primary endpoint was time to recovery within 28 days. The primary analysis occurred after just over 600 recoveries were attained. As you can see in panel A, overall, the time to recovery was shorter for those who were assigned to the remdesivir group as to those who received placebo. However, if we break this down by subgroup, among patients not yet receiving supplemental oxygen, although there was some trend towards benefit of remdesivir, this failed to achieve statistical significance. Among those who were receiving low flow oxygen, there was a significant benefit, but among those who were receiving either high flow oxygen or mechanical ventilation, there was again no benefit. So it seemed that the benefit of remdesivir was time limited in terms of when it was initiated. Too soon, and it was hard to demonstrate a benefit. Too late, it no longer had a benefit. This finding was confirmed in many respects by the Solidarity trial. This was a multi-arms adaptive platform trial, which included an arm with remdesivir in which participants were randomized again to remdesivir or control. But this study had as its primary endpoint in-hospital mortality. And what you can see is that there was no difference in survival among those who received remdesivir versus control. If we look at different strata within this study, you can see that there was really no difference in outcome based on age. There may have been slightly worse outcomes among those who were ventilated compared to non-ventilated, but neither of these were statistically significant when comparing remdesivir to placebo. And overall, there was a really minimal, if any, benefit, once again, failing to achieve statistical significance. However, if you combine all of the data from all of the trials, as Kaka et al. Did in their meta-analysis published earlier this year in the Annals of Internal Medicine, you can see that there is evidence that remdesivir does provide a benefit. Looking first at mortality, here in the analysis overall, there is about a 7% reduction in mortality that just fails to achieve statistical significance. However, if you break this down by baseline characteristics, the analysis focusing on persons not receiving any supplemental oxygen at baseline, we see about a 20% benefit that is not statistically significant, but among those receiving supplemental oxygen but not yet ventilated, so very similar to the population who were benefited in the ACT-1 study, we see that there is again about a 20% reduction in relative risk of dying, and that does achieve statistical significance. whereas among those who had more severe disease already ventilated or requiring ECMO at baseline, there was actually a trend towards a worse outcome, not quite achieving statistical significance. Looking at other non-mortality endpoints, in each case, there is a benefit for remdesivir. The side of the line that shows benefit varies based on the outcome. So proportion recovered, a higher proportion means you show up on the right side of the unity. And here we can see that remdesivir is favored, about a 10% better proportion recovered, which is statistically significant. Progression to mechanical ventilation or ECMO. So the lower the proportion, the better it is. And again, here we see in the fixed effects model, there is about a 30% reduction in disease progression, which was statistically significant. And reduction in serious adverse events, again, about a 25% reduction. So overall, there is compelling evidence that remdesivir can provide clinical benefit when used in the right group of patients. Well, let's turn now to look at SARS-CoV-2 monoclonal antibodies. Monoclonal neutralizing antibodies are able to neutralize SARS-CoV-2 by preventing virus entry or by leading to virus clearance and destruction. These antibodies all target the S protein. They can be genetically engineered to combine multiple specificities or to extend half-life. And they have potential utility for both treatment and prevention of COVID-19. This slide shows data from both the phase 3 trials of bamlanivimab plus etesevimab and the phase 3 trial of casirivimab and imdevimab. These studies were done in people who were not yet hospitalized, individuals who had symptomatic proven SARS-CoV-2 infection, who were either at risk for severe COVID-19 because of comorbidities or met specific age criteria, typically being over age 65. And the primary endpoint was prevention of disease progression, defined as the need for hospital or emergency department visits or worse outcome. And what you can see is that in both cases, there's a very clear benefit for the bamlanivimab plus etesevimab. You see that roughly 6% of the placebo recipients, but only 1.5% of the antibody-treated participants ended up having disease progression, and there were no COVID-19 related deaths in the antibody group. And in the casirivimab plus imdevimab group, likewise, there was about a 3% risk of progression in the 1,200 milligram arm in the placebo, and less than 1% for those who received the antibody. And in the parallel study that looked at twice the dose, there was about a 4.5% risk of progression among the placebo recipients and about a 1% risk in the antibody-treated group. So clear evidence that if used pre-hospitalization in people at risk for disease progression, these antibodies can have a benefit. Another antibody that's used as a single agent, sotrovimab, has also received emergency use authorization. There are fewer data available here. There's not yet a medRxiv preprint or published report here, but in this study of just under 600 participants, same idea, people at risk for disease progression who had symptomatic disease and PCR-proven SARS-CoV-2 infection. You can see that just 1% of the sotrovimab-treated participants versus 7% of the placebo had progression that translated into an 85% reduction in the adjusted relative risk of progression, a highly significant finding. Once again, no deaths in the sotrovimab group, only a single death in the placebo group. Now, in addition, although studies in hospitalized patients for both bamlanivimab and etesevimab and casirivimab and imdevimab have generally failed to show benefit, mostly because people already have made their own antibodies, and therefore exogenous antibody is of less utility. there's a specific subgroup of individuals in whom these antibodies may be helpful, and those are the people who have not yet made their own antibody or who can't make their own antibody because they're immunocompromised, especially if they've had anti-CD20 therapy for either treatment of lymphoma or treatment of certain inflammatory diseases. And so this is an analysis that comes from the recovery trial, another one of the large adaptive platform studies, which had a monoclonal antibody arm to it, in which casirivimab and imdevimab were the antibodies selected. And in this pre-planned analysis, the participants were stratified on the basis of whether they were seropositive or seronegative at study entry. And you can see that whereas among the seropositives, there's, first of all, an overall lower mortality rate. There is really no difference between those who received the antibody and those who did not. Whereas among those who were seronegative, not only is the mortality rate higher overall, but there's now a statistically significant reduction in the risk of mortality for those who received the antibody known here as REGEN-COV compared to usual care. If we look at some of the subgroup analyses, we can see that whereas for all participants, there was a trend towards benefit, but it was modest and doesn't reach statistical significance. If we look at by stratification of those seropositive or seronegative, you can see that there's a substantial reduction, about a 20% reduction in mortality for those who were seronegative, but no benefit for those who were seropositive. And then likewise, we see a higher likelihood of being discharged alive from hospital among antibody recipients if they were seronegative to start with, and a slower or lower risk of progression to mechanical ventilation or death among those who started off seronegative and received the antibody. Now, challenges with the antibodies are that the virus keeps mutating, and as different strains or variants of concern have been circulating, the antibodies have become more or less useful. And this was a particular concern for bamlanivimab because mutations that characterize the alpha variant, the beta variant, and the gamma variant may have effects on susceptibility. So the 501Y mutation, which is found in the alpha variant, actually produced no change in susceptibility, but the E484K substitution that's shared by the beta and gamma variants led to a substantial reduction in neutralizability of SARS-CoV-2 by bamlanivimab. Now, of course, BAM is used in combination with etesivimab, but even in the combination, you can see that there are significant increases in the in the reduction in susceptibility for the beta and gamma variants, which have this trio of mutations that characterize these variants of concern. For this reason, for a period of time this spring and through the summer, bamlanivimab and etesivimab were no longer being released by the US government for use. And in fact, the emergency use authorization for bamlanivimab as a single monoclonal antibody had been withdrawn. By contrast, for casirivimab and imdevimab, there was really no change in susceptibility for any of these variants. Likewise, for sotrovimab, we see that there is no change in susceptibility for the alpha, beta, or gamma variants, and this antibody is used as a single agent. I should point out also that sotrovimab has the LS variation or a mutation introduced into the FC domain, which leads to much longer half-life. Now, all of this is flipped on its head because the Delta variant actually is highly neutralizable by bamlanivimab and etesivimab, and that combination is now once again being released for use in the United States because the predominant strain, of course, is now Delta, with more than 99% of cases in the US currently attributable to Delta. Let me just mention very briefly of the use of these antibodies as post-exposure prophylaxis. So this talk was really on treatment, but these antibodies are highly effective as PEP in people exposed to others with SARS-CoV-2 infection. The study on the left shows the use of bamlanivimab by itself. This was a study done as a collaboration with the NIH and led by Mike Cohen. Here, nursing home residents in facilities where cases had been documented were randomized to receive placebo or bamlanivimab, and you can see the dramatic and highly significant reduction in the proportion of residents who developed symptomatic SARS-CoV-2 infection. Likewise, the combination of casirivimab plus imdevimab was studied in household contacts of people who had developed COVID-19. And you can see, once again, the administration of the combination antibody results in a dramatic reduction in the incidence of symptomatic SARS-CoV-2 infection. Casirivimab and imdevimab now have an emergency use authorization for use as post-exposure prophylaxis, although the logistics of delivering that preventive therapy have been daunting. It's unclear where bamlanivimab is heading, since there is no EUA for bamlanivimab by itself, and there are no data on the use of the combination as prevention therapy. So let me conclude by saying that remdesivir and monoclonal neutralizing antibodies play a role in the treatment of symptomatic COVID-19. Treatment is most effective when initiated early in disease. Potential role of monoclonal antibodies for post-exposure prophylaxis is really substantial, but faces many challenges in effectively delivering that preventive therapy. And therapeutics will continue to have a role even in the setting of widespread vaccination, as we're seeing now in the United States and other parts of the world, where the pandemic continues to rage among the unvaccinated and then causes breakthrough cases even among some of those who have been vaccinated. So thank you very much for your attention, and I'll turn this back over to our moderator.